we are going to launch a new version of our mobile application. And whenever we do clinical practice, we are often challenged with scenarios where we don't remember everything, we don't understand the approach, and we don't understand the figures. We want to use some calculator, and it's very difficult to do it on a day-to-day basis. Now, I always thought that when you are managing a case, like a challenging case comes to you, let's say of a persistent hyperinsulinism, the conventional approach is that you go back to the books, start reading from there, try to get back, and then decide how to manage. The problem of this approach is that most of the time you'll start off with pathophysiology, then you will go on to what are the causes, then you will go to evaluation. So by the time you reach to the management, it becomes difficult. So what we have been trying to do and what we have been thinking for over a decade is to bring those algorithms that have been developed into real practice, which make it very easy and to do it on a point of care fashion. These are relevant predominantly for people who have less exposure in pediatric endocrinology, but also helpful for everybody. So if you're using it and you're sure that this is the way it should go in a precise manner, the applications will help out. So we started around 5 years ago, and today we're going to start off with many new formats of these interpreters, which will allow us immediate evaluation and management on that perspective. So over the next 2 hours or so, we are going to really highlight how these solutions can help out in terms of our day-to-day pediatric endocrine care. Now, why we started thinking of developing these tools was this case, whom I managed when I came back immediately, maybe 15, 16 years ago, was this 7-year-old boy with short stature who came to us at a time when nothing could be done, in that the bones were fused. Now, this is not unusual. Still, 10 to 15% children come to us at a very late stage. What was unfortunate in this case was that he had all the features of celiac disease. He was TTG positive, but unfortunately, because of the severe anemia he had, that was maybe around that 5 to 6 years ago, he was evaluated by a pediatrician who advised blood transfusion, which culminated into HIV/AIDS. So a reversible thing, a very simple thing like celiac disease turned out to be in a very adverse scenario. And that made us think what could have gone wrong and how could we have improved in that regards. So the most important thing in terms of the improvement of care of any particular individual with a health disorder is awareness. If the patient is aware at the right time when to go to the doctor, if the doctor is aware what things to order, how to evaluate, we can prevent most of the things. Accessibility to specialists is number two. Affordability is last. So often people think of pediatric endocrinology that you need very expensive investigations in a very complicated scenario, which is not true. If you do it at the right time, you can identify in that regards. Now, how do we really have a true evidence-based clinical practice? For that, there are multiple things that we need to implement. Of course, there are a large amount of books which are available. You have to put all that knowledge back into clinical practice. This involves ordering rational tests, especially in resource-poor settings where you can't just order every test all the time. You have to use that in terms of algorithms. You have to understand about the various drugs, the interaction, how to use, what dose to use, and then finally you have to take everything up to make that. So the process of a rational management of a child with endocrine disorders, of any child, requires a comprehensive combination of diagnostic, therapeutics, approach, management. All this perspective is important. So we tried to build up resources which will help us in terms of overall improvement of pediatric endocrine care initially in the country and then beyond that. So we started with workshops. So we have conducted over 200 workshops across the country. But that itself is a very tedious process, and the retention of people is not a long time. So they will forget. Maybe once you do a workshop, 1 week later, everything is gone because they're not implementing in the clinical practice. We started with practical courses. So 15 courses have been done in the country, but they are extremely resource intensive. You would need a lot of time, energy, money, everything. So it's not easily feasible. We started with our YouTube program, which provides a lot of free channels. So this is also there. We started an on-site fellowship. So till now, we have 14 fellows who have joined. So this is something. But then again, the reach is limited. To take it forward, we started with our MedEClasses, which was our online portal, which takes it beyond the routine classroom to beyond so that people can use that knowledge and understand in a systematic fashion, brought up the textbooks. But then at the end of it, what we realize is that unless and until we have something in the hands of a physician at the time of management, they would not be able to take the implement all this knowledge, because knowledge is there. Unless you see it day in and out, then it's in your reflex. Otherwise, you will forget. So then we thought 5 years ago to develop a mobile application, which at that time was a unique way of managing cases, and still now it is one of the very rare ones in that perspective. So as I said, we have done a lot of pediatrician initiatives across India and abroad, including a lot of workshops, practical courses, advanced courses in that perspective. Our e-learning portal has got huge number of videos and a lot of watch time. We have organized learning, which is a validated program at learning.growsociety.in, which offers courses for pediatric endocrinology to various aspects, starting from the fellowship program to small fragmented courses in that regards. And these have been accessed from people across the globe, which has culminated in that. We have got 3 publications, both basic, advanced, and protocols which form the basis of many of these applications. So all these algorithms that we use now are largely based upon many guidelines plus clinical experience, and many of these are already published in these books. So we have used that to translate these books right away for clinical management. So the MedEClasses Endocrinology was the app which was basically released around 5 years ago. It is the most downloaded pediatric endocrinology app, or an endocrinology app, so to speak, with 10,000 installs. There are multiple places where it has been presented, multiple awards have been given. There are publications also which have come out from there. Now, the crux of this app is to try to translate what knowledge is in terms of clinical practice. So the most important ones which started off were approach pathways. Now, how these approach pathways were working was like these flowcharts. So there will be questions which people will answer, and based upon those question answer, we would be able to achieve the diagnosis in that perspective. And this is how you will read. So based upon your results, the next question will come up, and then subsequent to that, a final diagnosis will come up. So this was a stepwise approach. It simplified the algorithm. Now, if you have, let's say, algorithm pasted in front of you also, it may be more difficult, but if you get precise answers, it made it much easier in that regard. So there are covering entire parts of pediatric endocrinology in the approach pathway. There are management pathways similarly, because many of these scenarios, like if you think of increased insulin effect, how do you decide which workup to do, what to do? So we developed these management pathways. This allows implementation of algorithmic approaches and management on a clinical basis. So it gives you a personalized guidance. Now, the problem with these pathways is, which I don't think it's a problem, it's part of their way they have been developed, is that it will take a bit more time and you will have to put inputs every time. This is an advantage also, because then you can get a much more detailed picture of the clinical scenario. But often in this day and age, we want instantaneous results, that we want immediately that you input the data and you get the output. So for that, what we tried to develop was interpreters. And one of these interpreters is like Thyroid interpreter, which Dr. Vibha will talk a bit more, in which what you do is that you just enter your analysis, and based upon that, you will get the diagnosis as to what you're dealing with. We have now largely taken forward a number of interpreters, and this time which we are going to launch is interpreters which are holistic approaches for complete electrolyte disorders in a single interpreter, hypoglycemia, calcium, and these interpreters have become, they are instantaneously more helpful because they give immediate results. But we need to remember is that because they are based upon one-time input, they may not be as encompassing as compared to a approach pathway. So often if somebody uses that, like here what it says, follow approach pathway as well. So this is for the initial guidance, and then you can go ahead and use the approach pathway from that perspective. Now, of course, when you say that you do a particular test, let's say a AMH test, you need to understand when to do the test, how to do the test. So you don't want to go back to the book and open it up. We have a full diagnostic section which provides what is the timing, what is the sample type, what is the reference range, and everything is available within the app. So within a single app, you've got all the information. Similarly, if you want to prescribe a drug, there is a therapeutic section which really provides the detailed information. So all the drugs which are used in pediatric endocrinology are there, and we give all the adverse effects, interaction, and all those parts in that regards. Many times in pediatric endocrinology and other aspects, you want instantaneous calculation of things. And this is something which we have provided. And this is not only simple calculator, it is also helping us in scoring system. So like external masculinization score, often people will forget. Those who are not using it regularly won't remember. So here you will get what exactly you have to input and you will get the result. Similarly, bone age, this was a Achilles heel for pediatricians. So this was a major development which we did in terms of developing a bone age tool which uses only 5 sites to provide an accurate estimation of bone age, which can be done rapidly even via a non-expert. So this is something which has been used now across the globe. This has been published and validated, and we are going to make it even more simpler, hopefully soon. And things like Ferriman-Gallwey score, which may not be possible for the patient to examine right in the clinic, we can ask the patient to self-rate and they will give you a picture. So this is going to help you provide an objective estimate of clinical parameters. Now, many people say, okay, we now have a pathway, we now have interpreter, but we want to learn a lot. Now, what we have done is that entire knowledge bank, which is there in our website, is provided here as well. So if you want to read a particular thing without the figures, otherwise the load will become too big. The app will become a lot of GBs there. You have got all the textual information you can read about any particular condition. So entire knowledge pathway is there, and you can also test your knowledge using the mobile pathways in which questions are there, which scenarios can be used. So what we have tried to do is to bridge all the things, including diagnostics, therapeutics, approach, analytics, to get the clinical management based upon the latest state-of-the-art guidelines from that perspective. And this is something which we wanted to do. So a lot of awards have been given. So in 2019, we had the presentation as far as the bone age interpreter is concerned. Dr. Riddhi had presented that and won 2 awards, one from the IAP Research Conference and the Indian Society of Pediatric Endocrinology in 2019. Dr. Sayan won the award and the West Bengal IAP in 2022 regarding puberty interpreter. Then we had a good presentation on bone age in the novel tool used by Dr. Naveen at the Asia Pacific Pediatric Endocrine Society conference in Seoul. Dr. Vibha has been presenting many of these ones, including in the American Thyroid Association, including the thyroid interpreter. Then we had Dr. Alapan, who presented the diabetes interpreter at the Asia Pacific conference. Dr. Dhwani, who won the DSD interpreter. So a lot of publications have come out from there, including the growth chart, the decay management, and the bone age assessment, and many more are on the way. So what we're going to do today is to try to cover a wide variety of pediatric endocrinology and how our tools can help us.
As we know, thyroid function test is the most screening test that we do usually in our OPD. So TSH has a 40% diurnal variation and 50% interday variation, but it does not affect the interpretation. So TSH can be done at any time of the day. T4 has a TBG effect, so always free T4 should be done. And T3 is of no use because it has MDI effect and it changes in lots of scenarios. So in case of hypothyroidism, the first thing that happens in the body is the increase in the TSH and decrease in the T4 level. There is also decrease in the T3 level, which happens at the last. So the most important investigation that has to be done in the hypothyroidism is TSH and T4. While in the case of hypothyroidism, the first thing to decrease is the TSH, then both the T4 and T3 are increased. And all the three, TSH, T4 and the T3 are the important and the useful investigation in case of thyrotoxicosis. So while interpreting the thyroid function, we know there is a log linear relationship between the free T4 and the TSH. When the T4 level goes down, the TSH increases, and if the TSH is above 20, that it means it is a case of primary hypothyroidism. And if the TSH is below 20, that means it is a case of central hypothyroidism. While when the free T4 increases, when it is high and the TSH is undetectable, this is thyrotoxicosis. And in case of high FT4 and detectable TSH, it is a case of TSH adenoma. So it looks pretty simple to diagnose the thyroid disorders, but in some cases like the central hypothyroidism, TSH adenoma, it is quite confusing. So we have developed this thyroid interpreter, which is available for 4 categories: the neonates, children, non-pregnant adults, pregnant adults. we have to enter the free T4, which is available. We can go for the nanogram per dl as well as for the picomole per dl, because we get FT4 levels in all in these two units, and we have to enter the TSH, and within a single click we'll get the most likely diagnosis. We have developed MedEClasses thyroid tools, the approach pathway for the congenital hypothyroidism, the acquired hypothyroidism, and the thyrotoxicosis as well. So if we see, the neonatal screening is very important, and it has to be done at the day 3 of life, because there is a TSH surge which starts at the birth, and the serum TSH is twice of the whole blood levels. So if the TSH at the day 3 is more than 40, so we have to repeat the free T4 level, and we should start the treatment immediately. And in case if the TSH is less than 30 and the space is if it is 34, if between the 24 to 48 hours, then no treatment is required in 99.9% cases. But if the TSH is between 20 to 40, we have to repeat the TSH after 14 days. And if it comes more than 20, then again repeat the free T4 and treat the child. If it is less than 10, then no treatment is required in this case. But if it is midway between the 10 to 20, then repeat again after 21 days and see whether the TSH is more than 20. And if it is, repeat the T4, FT4 and treat the case. But if it is between the 6 to 20, definitely we have to repeat the FT4. We should scan the thyroid gland and treat. We can wait till the scan, or if we want, we can start the treatment immediately. But if it is less than 6, then no treatment is required in these cases. Rescreening after 2 weeks of the birth is required in cases of prematurity, the children with trisomy 21, same-sex twin, and the children who were hospitalized during the neonatal period. So if we see, we have a day 4 child with a TSH of 22. At the day 13, it becomes 18. And if we see in the interpreter, if we enter the value, we have seen that at the day 13, if it is 18, it will show that it is a borderline abnormal thyroid screening. We have to repeat the TSH after 2 weeks of life and do the thyroid scan. And if it is above 20, we have to start the treatment. And at day 12, day 21, it was 11, and normal, the FT4 was normal. So we have seen that if the FT4 is normal, it is likely primary hypothyroidism, and we should consider thyroid scan in this case.
So I think this is very important that many milder sluggish cases may have some cause, which is like hemagenesis, which can be missed out. So we need to be cautious about in that regards.
So this was the case of hemagenesis, and a scan is to be done in these cases. We have this 10-day-old child with a TSH of more than 100. And if we see, the FT4 was 100, which was pretty low. On the scan, there was no thyroid tissue detectable. So the question is what to do here. The plan is, we did the ultrasound, and there was eutopic thyroid. And on the history, we found that mother has hypothyroidism. So if we put all these data in the interpreter, what we have found, this is the approach pathway, and we see that it asks for what is the free T4 level. If it is less than 10.3, then it will ask what is the TSH, what is the finding on the nuclear scan, what is the finding on the ultrasound. Then it will get likely apparent athyrosis due to the maternal TSH receptor blocking antibody.
Important scenario in which absent scan is there. Now, this absent scan does not mean that there is no thyroid.
No thyroid.
So what are the other possible causes? When we discuss about the TSH receptor antibody, what are the other causes of apparent athyrosis?
So other could be NIS, sodium imported effect.
Yeah,
imported effect, and this TSH receptor defect. Yes.
And rarely iodine exposure, if it is there, that can also cause similar scenarios, so which we have to be careful about.
So moving towards the approach of hypothyroidism, in the this we will first look what is the free T4 level, and if it is free T4 level is low, then we look for the TSH level, and if it is above 20, then definitely it is a case of primary hypothyroidism. But if it is below 20, then it is central hypothyroidism, and we should go for the MRI brain and the cortisol levels. And if the free T4 level is normal, And then we'll see the TSH levels. If it is below 6, normal, no need of any treatment or workup. And if it is more than 10, definitely it is a case of primary hypothyroidism. But if it is between 6 to 10, and we'll look for the risk factors like the TPO positivity, goiter, family history, and if it is a girl child or a boy. And if the risk factors are present, definitely we have to treat these child. And if there is no risk factor, then we have to follow up these cases.
So I think this is very important. You'll discuss that most children, whether they are obese or lean,
yes, sir,
with 6 to 10 will improve
on. Yes, sir. And now moving towards the case, we have this 12-year-old girl who presented with lethargy. Height was 140 centimeter and weight 36 kg. Free T4 was low, 6, and TSH was 9. So here, most of the pediatricians or the primary health cares make this error, and they label it as a primary hypothyroidism. So let's see what the thyroid interpreter says. We have to put the free T4 value, that is 6, and sorry. And in this case, the thyroxine was started from the pediatrician. And when we put all these data in the interpreter, it said that it is a case of central hypothyroidism, and the cortisol levels and the MRI should be done in these cases, and cortisol should be replaced before starting the thyroid.
So two situations wherein this, I would say three situations in which the thyroid interpreter can really help in the community practice. One is about the neonatal screening. A lot of people are unaware about what cutoffs to use at 0, 7, 14. So this is there. Second is this, even if we say one central hypothyroidism from being treated and going into adrenal insufficiency, that is important. And third, of course, is the thyroid nodule, which will come up later.
So coming to the thyrotoxicosis, definitely we should avoid for the nuclear scan if there is a goiter in the eye sign present. And if there is no, then nuclear scan is advised. And if there is increased uptake in the nuclear scan, it could be a solitary nodule. It will present like a small solitary nodule, like a localized lesion. And if there are multiple lesions, increased uptake, that it will be toxic MNG. And if it is a diffuse uptake, definitely it is a Graves' disease. And if there is a decreased uptake, tenderness present in the neck, so it is a case of subacute thyroiditis or the chronic lymphocytic thyroiditis. So next we have a case of 12-year-old girl who presented with tremor. FT4 was high, it was 34, and TSH was less than 0.01. There was swelling in the thyroid gland, but there was no eye sign. She presented with tremor. Now the question is what to do with this child. And when we put all these data in our app, we have seen this is the approach pathway, and it has asked many questions. What is the free T4 level? What is the presentation? And it will provide what should be started, what dose of the methimazole should be started, how should we follow up the case, and what are the adverse effects, and how long should we treat this child, and when the child could present with a relapse if we stop the child. So this approach pathway provides us so many information with the case with thyrotoxicosis and as well as the hypothyroidism.
This is clearly a case of Graves' disease, I think, from that perspective.
Yes. So this, we have a very interesting case of 10-year-old girl who presented with thyroid nodule. And on the USG, it showed that it is a 3 into 2 centimeter. It was firm, mobile, and TSH was 1.2, that is euthyroid. And on the ultrasound, it showed it is a solid cystic characteristic. The question is what to do with the child, whether we should reassure or go for the workup. When we put all these data in our app, we have seen that this interpreter has provided that the child should go for fine needle aspiration after 6 weeks and consider molecular study with a diagnostic lobotomy for the high-risk cases.
So around 7 to 10% of all thyroid nodules in children will have malignancy. So if it's more than 1 centimeter with polycystic appearance, you have to do that. Problem is that there are specific ultrasound-based criteria along with the clinical criteria which you have to decide, which are often missed out. Recently, there is some pediatric validation of the TIRADS criteria as well.
Yes, sir, they are doing, but they are not pretty sure whether they have to be applied with the pediatrics or not.
Yeah. So what we do in terms, this is the novel interpreter which we are putting in now, is the thyroid nodule interpreter. So what it is looking at, it is looking at TSH to
Yes.
classify into functional versus non-functional. Then it talks about the radiological appearance. If it's a non-functional lesion, in adults, we do our whole thyroid scoring. In children, we just have a basic criteria as you discussed and then decide whether FNAC is needed or not. So like this case,
So we had this 15-year-old girl who presented with the thyroid nodule. The size was 1.5 into 2 centimeter on the ultrasound, and it was firm and mobile on examination. And when we put this information in our app, it has shown that the TSH, when we put the TSH of 0.01 and the thyroid scan of worm nodule, we have seen that it is
so this will basically, so this is clearly a case of toxic
nodule.
And there is a warm nodule, which means that there is a risk of developing malignancy. So we should do a FNAC in this scenario. So if you're looking at TSH is
0.01 and the radio tracer uptake is worm nodule. Fine needle aspiration says then we have to go for the FNAC, and the interpretation says that we have to follow up after 1 year for size, and we have to follow the management for the thyroid nodule.
So these are largely based upon the European Thyroid Association and the American Thyroid Association guidelines. And adults, there is specific thyroid criteria. In children, it's not easily available. But I would say that this is a very good presentation overall. Thank Vibha for that. And so if you look at three major goals, I think one is neonatal screening, when to think of, how to think of, how to interpret. Second, about central hypothyroidism. Third, about the thyroid node. Now, more of people think about that if you have technology, it is going to replace the physician. It's not going to. Technology is there to assist the physician. And if we do not move with the technology, then we may be left behind. So what our aim is, definitely not to replace any clinician. It's just to support, aid, guide. Sometimes you're not sure about what the guidelines would suggest, what level is appropriate, how to do those calculations. The app is meant to help out. And it also specifically tells you where you need to seek a specialist opinion as well. So this is mainly to assist people at all levels. And our studies, if you look at the interpreters for DSD, for diabetes, it may also be helpful not only for the training pediatricians or the pediatricians, but even for endocrinologists and pediatric endocrinologists. So just to ensure that you have a continuous growth, you can just have a look as to what it is suggesting. And then final diagnosis treatment will depend upon, of course, the overall clinical scenario. So we encourage all of you to go and have a look at our MedEClasses Endocrinology app. It's available both on Android and iOS store. In the first 7 days, it's free for use for everybody. So you can have a look at it. And then it's available for subscription at a nominal fees in terms of the clinical perspective.